Hello, everyone, and welcome to the Cardiovascular Learning Action Network, or what we call the Cardio Land. For those of you who haven't met, my name is Cindy Sun. I'm one of the HHQI RN project coordinators. This is the June 2017 event being held in July of 2017. And for those of you who were not present at the original date, this rescheduling was due to Mother Nature having a bit of an attitude at our guest speaker's location. Due to an electrical storm, it caused our guest speaker to lose all our forms of communication to the point that we really had to just cancel mid-webinar. And that was a first for any of us, but, you know, that's always a possibility in our virtual world. And we're just very fortunate that Melinda was able to fit us back into her schedule again for this do-over. Now, whether you're part of the returning group from June, or you're new to this time, or maybe you're listening to the archive recording, we want to thank you for taking the time out of your schedule to join us as our guest speaker presents Partnering with Patients to Make Non-Compliance a Thing of the Past, 5 conversational skills to make this happen. Really, our goal for this is just that you will be able to take the information that she shares on today's webinar and begin applying it in your own settings 1 hour from now. Today's session has been approved for 1.25 nursing CEs. And I'm not able to change the slide there, but I'll just tell you that 1.25 hours of nursing CEs have been approved by the Alabama State Nurses Association, an accredited approver of the American Nurses Credentialing Center's Commission on Accreditation. And we'll give further instructions on this towards the end of the presentation. Now, as far as announcements go, I'm going to actually push these towards the end of the presentation so that we can get started. I will go ahead and mention that we kind of have a request or an ask of you that I'll mention at the end of today's session, and I hope that you all can stay around because we do need your help on something. Now, as everyone's settling in, I will just go ahead through a few of the housekeeping items and mention that this webinar is being recorded, and it will be archived and posted under the Cardiovascular tab on the HHQI website under Cardio Land Webinars, and that's also where you can download today's slides if you're so inclined. Due to the volume of participants, we're going to keep all the phone lines muted, and we encourage you to use the chat and the Q&A features on the right side of your screen. If you're not seeing those features, you can click on the icons at the top of your right side of your screen, and that will make them appear. And we're going to get to as many questions as we can as time permits today. This specific session will be very interactive, and it's more so than others. And I want to encourage all of you, the same as us, to really decrease multitasking and try to take advantage of our guest speakers' knowledge and our willingness to share during this experience. As you can see today's objectives, we hope that you will learn to identify an example of successful patient partnership, explain how engagement will affect patient outcomes and satisfaction, and describe 2 conversational skills to improve patient engagement. Now, I know some of you already have met Melinda, our guest speaker today, but if not, I would like to take a moment to introduce you to her. Melinda Huffman, BSN, MSN, CCNS, CHC, is a co-founder of the National Society of Health Coaches. She's a nationally known speaker and writes regularly for peer-reviewed journals, newsletters, and guest blogs on evidence-based health coaching, chronic condition, and behavior changes. She's a former Director of Disease Management for Amedisys Incorporated, Director of Nursing Education at Motlow College, and Assistant Patient Care Administrator for Southern Tennessee Medical Center. Melinda has a BSN from the University of Alabama, Birmingham, and an MSN in Cardiovascular Clinical Nurse Specialization from the Catholic University of America in Washington, D.C. Please join me in welcoming Melinda to the Cardio Land. Melinda, the webinar is yours.
Thank you so much, Cindy. I really do appreciate your having asked me to return, especially after that terrible debacle with the storm. Hi, everyone. It's wonderful to be with you. Today, it's going to be hopefully very interesting for you and for me as well to share with you many things that we've learned over the past 10 years in being with the society and opening the eyes of healthcare providers into what patient engagement can truly become. We see a lot about patients being involved in committees, patient rounds, even the EMR and the PHR becoming a true engagement tool. Well, while those things are true, There's nothing we believe that's more important than engaging every single patient that you touch in a different way, whether it's by the bedside, at the home, at a home visit, in the exam room, in the clinic. It does not matter. Every single patient can be guided differently than what we have in the past to actually improve outcomes, to improve that satisfaction. And we have heard clinicians actually say to us, I feel more like a clinician today after going through this change of mindset and training than I ever have before. And it's fun. So let's go ahead and get started. First, a very brief story about my dad. A few years ago, actually it's been a couple now, he ended up with a fractured vertebra and ended up in the hospital naturally. And we, as we were preparing for that inpatient hospital rehab and then ultimately for home care, I asked the individual, because my mother is his primary caretaker. She was 88 at the time, he was 91. So we're already dealing with elderly patients and family caregivers. So I asked the case manager, could we please have a meeting together? Could my mother and I come and sit down and talk with them about our situation at home, because they were living in their home with me living next door. And I was a very nice case manager, but she said, oh no, now I want you to listen carefully to this. She said, oh no, don't worry about that. We will tell you what you need to do before you discharge. We'll each come in, each of the therapists will come in and tell you what you need to do. Okay, now I want you to remember that. So it was getting close to discharge day. His stay in the inpatient rehab was complicated by a patient fall and pneumonia. So we moved forward. The nurse came in to do the discharge. And she was going through a lot of the medication list and her to-do list, because remember, we all have our agenda. When we interact with a patient, we have our agenda. Now, whether it's on that sheet of paper that we've got to complete or whether it's in our minds, meaning we've got 2 other admissions today, I've got 4 more patient visits, I'm on call tonight, I've got to get the on-call book or the on-call electronic record. We have an agenda, and it fills our mind and it fills our day. The nurse comes in, and after she's gone through that, and she looks at my mother and she said, now you'll be on oxygen, you know, he'll be on oxygen when you go home. And immediately my mother says, oh no, I don't want that tank in my house. The nurse very kindly looked at her and said, but you want him to breathe, don't you? Still very nice. Of course, as a health coach, I thought, oh my goodness, what opportunity she has missed to engage my mother as the caregiver and my father as the patient, both very alert, very unusual people for their age. What a missed opportunity. I call it angels unaware. I want you to keep that scenario in your mind as we move forward in our discussion today. First of all, it's important to change our mindset. We've got to be open to changing our mindset. Our traditional way of managing patients is directing them and telling them what to do. And what kind of things do we tell them to do? It's a do these things kind of mentality. And some of you may still have that director approach. And the reason we have that is because we've been trained to be the experts in our field. So our mindset tells us if you do what we tell you to do, then you will have optimal recovery, better outcomes, improved patient experience, and so on and so forth. When in fact, and what kind of things do we tell them to do? Diet, exercise, medications, when you're going to go back to the doctor, when is your follow-up appointment, what are your adverse signs and symptoms that you should be aware of, and the beat goes on. And if you don't do these things, if our patient doesn't do these things, then we do have a label for them still, although I will say that with the advent of health coaching, really noncompliance has taken on that negative connotation that we're happy that it has, because we like to believe that noncompliance is really a thing of the past. Once you begin to use these skills, of course you have to be trained in these skills and use these skills, things will change for you and will change amazingly for your patient. But still, there's many people that do have a label, and it's called noncompliance. We even have at some point, our beneficiary notice would tell us if the patient isn't being compliant, you have the right to discharge them. But we would like to take a whole different approach to this. But look at what our traditional agenda looks like in process. We're telling her what to do. We're kind, we're caring, we're concerned, we're very deliberate because we want them to get that information. And it pretty much revolves around health teaching, not necessarily about what we're saying. So we're going to change all of that in health coaching. Evidence-based health coaching changes our conversation. And health teaching becomes a very small component of a much larger skill that we are using. So look at this little patient. Look at the expression on her face. If we were more in tune to our patients today, we would probably realize, they're looking at me, so I'm not handling this situation like I should. And we treat them like information receptacles in many cases because it's not because we don't care, it's because we have an agenda to complete. What does health coaching with the motivational interviewing accomplish? It's partnering and it's engaging. Now, I want you to think of a partnership. We're going to say it's a 50-50. Okay, so what have I been doing? We've been doing a 90-10, I would advise you to consider. We've been doing a 90-10 with us doing 90% of that talking. How will this new medication affect your daily routine? How many of us really ask that question? We may say, even the pharmacist, do you have any questions? No. And the patient may say no, not because they don't have any, but because they really haven't thought it through. And our new approach has that patient thinking through the way we question and pose our question. So we get real solid answers that we can help guide them through that maze. What concerns do you have about the medication? What thoughts do you have about taking this medication? Because today, we know this is the this is the decade of information age. Even if an older patient doesn't have access to the internet, they certainly have children and grandchildren who do, and they will oftentimes ask, I'll ask my grandfather or my grandchild to, can you get that off of that computer for me so I can read about that? So they are very highly informed. So now we're going to a brand new way of thinking. And in order to make that leap for us as traditional clinicians ourselves, we need to know a very important piece about how we facilitate behavior change. Because even if we consider the health teaching we do, and even if they are on what we might consider a minor medication change, it may require a health behavior change on the part of the patient. So no change is too remedial, if I may use that term. So let's look at this. We know, and I just saw a new stat yesterday that up to 70% of the patients don't take medications as prescribed, nor do they follow treatment plans as ordered. Now, I want you to think of ourselves. We truly are them. How many times, and I know I have, so I'm certainly at fault, how many times have we, as clinicians, gone and bought a prescription, paid for it, didn't start it? How many of us bought the medication but yet took it but not as prescribed? I would suggest to you that many times it's not, as clinicians, it's not because we know how to manage ourselves better. It's the very same reasons that our patients have. And it has to do with how that change affects our lives, our daily lives, the social context of our lives. And health teaching, my friends, does not equal self-management. So let's look at that 90%, 10% partnership, and we're going to turn that into a 50-50 partnership. And just a little humor, think about this. I'm taking better care of my heart. I started using aspirin as one of my pizza toppings. That may not be necessarily because he didn't know. It also can be because, well, I'd like to do it this way. So I think I'm just going to do it this way because of the way that I like pizza and I like to eat. It's how it fits into his daily life. Think about this. Change is similar to an iceberg. Only 15% is visible above the water, but that driving force is deep below the surface. There's 85% that's susceptible to change in currents. The very same thing is at play when we're working with our patients, when we are guiding our patients, when we're teaching them about a subject matter. When they hear anything we say, it is having to do, they're translating that to, how do I really feel about that? How is that going to change my life? Now, we're not talking about getting back into the workforce and how that's going to change me long term. We're talking about today. And typically, when we say, well, do you have any questions? The answer is going to be, no, I'm fine. We're not even giving them time to really think it through, and we're not posing our questions in a way that has them to think it through. Why don't people change behavior? Their values don't support it. They don't think it's important. They don't think they can. They haven't worked through their ambivalence. I would exercise every day that I'm supposed to, but gee, I get home late at night from work and I'm just too tired. Or I would do better with my blood sugars, but I'm telling you, we just love to eat and I just can't resist that dessert at times. It's the but in the middle that causes the problem. And we'll talk about that again in just a moment. People don't change behavior because they're not ready. They don't have a good plan. They don't have adequate social support. Now, this is coming from people themselves in a huge survey that was conducted by the Oregon Health and Science University. If we can understand this component, if we don't take anything else away today, but why your patients aren't changing their behavior, this will be one of the key takeaway points for you today. When you're having and meeting patient resistance, think about these things. That's telling you, I've got to use my new skills, my new conversational skills to help drill down, and it doesn't take very long. It's not counseling. It's simply a new, different way to position and pose your questions. Because face it, we've been trained to have a lot of yes, no. In a physical assessment, in our documentation forms, yes, no, somewhat, and then we describe. So this is very new for us. It's not typical. So we're going to be seeking to establish that partnership. And how does a 50-50 partnership work? Well, the patient certainly should be talking 50% of the time. And you may say, oh, Melinda, gee, when I'm in the home, if I sit down and allow that patient to do the talking, I'll be there all day. And I've got this many patients to see. But remember, what we're doing today, typically, if you haven't learned these new skills, if you're not using these new skills, we're allowing that patient to rabbit trail off into some subject matter that's important to them because you want to be respectful. We're not guiding that conversation. We'll have new skills to guide that conversation. The premise of that the partnership is that we provide the clinical expertise just like we always have. But remember, when you think of that 50-50 partnership, we're not getting into the social context of that patient's life for them to be the expert in the other 50% of that relationship. These skills can be learned, health coaching with motivational interviewing. So how does it differ? We're going to move from a traditional, diagnosis-driven, unmeaningly creating a dependency because of the way we're conversing. We're doing the talking, and it's our agenda that we guide that conversation by. With a 50-50 partnership, now we're going to be engaging them very differently. We're focused on their concerns. We're also going to have skills that will empower that patient where they know that they are important and autonomous in that relationship. That right there does huge things. The patient is talking, and it's the patient's agenda because it's going to be what is going to affect his life that we're telling him to do that creates issues for him to comply. These 5 skills we'll only touch upon, and I must say we're rushing through this. I feel myself talking very rapidly only because this is going to be a taste. And you will have a couple of skills that you'll remember and that you can go back to your handout and think, okay, I think I'm going to try that tomorrow. But it's certainly not the whole of the skills that would make you feel more confident and, of course, confident in using this. But I encourage you to at least try. So today you'll get a taste of open-ended questions, affirmation, reflection, empathy, how to avoid creating resistance, and how to empower by asking permission and providing health information. So motivational interviewing is the very foundation of our evidence-based health coaching approach. It's a collaborative way to help people work toward and commit to the change by exploring and resolving their ambivalence to it. Remember, When someone doesn't change their behavior, there's a reason why they don't. No matter what that behavior is, only think of yourself, and you can come up with some of those answers that our patients also struggle with. What is ambivalence? Why I need to, but why I don't. Stuck in the middle is what we call that. I want you to briefly, just for 1 minute, we're going to take 60 seconds. If you have a pencil or a pen on a scrap piece of paper, if you have your handout, just flip it over on the back. I want you to make 2 columns. One, as a header, I want you to put a health behavior that I've wanted to change, but I haven't, okay? I want you to draw a line through the middle. On the left-hand side of the column, reasons to change, and that would be your personal reasons. And in the next column, reasons I haven't. Please take 60 seconds to complete that activity, and this will show you in no uncertain terms what your patients and families are grappling with every day. Okay, our 60 seconds are up. I want you to just take a look at those lists. If you're grappling with it still, you probably have as many reasons on the left as you do on the right. And that's where patients and us as people get stuck in the middle. I would do this, but for that. If you don't have as many reasons on one side as the other, sometimes those can weigh more heavily, and that causes someone to get stuck. So when you think of noncompliance, think of this exercise. If you're dealing with patient issue, think about this exercise and know for a fact that there are reasons in their in the social context of their lives as to why they are been unable to move forward. And it may be because we haven't helped them deal with and to uncover that ambivalence and map out some steps for them to map out, to help us together map out those steps to manage that. The spirit of motivational interviewing, and this is scientific, how I am with people and what I say, but what I help them to say will make a difference in whether behavior change happens. Motivational interviewing has had over 40 years of scientific research on the efficacy and safety of this and the actual working of this method, so know that it does work, and over 300 studies in research. And we do tend to believe what we hear ourselves say. So that's why the conversation is so much more important, and that conversation is a two-way street. Why it's so important for the patient to be involved in the conversation and not for us to be directing all the traffic. The more one talks about the reasons for change, the more likely they are to change. And the conversation that we use will help bring out or evoke from the patient the reasons for them to move forward in changing, to be compliant with that medication or with their treatment plan or with their exercise program or whatever it happens to be. There are several components of ORS: open-ended questions, affirmation, reflection, and summary. We'll move through these pretty quickly. So what does motivational interviewing, and just ORS is a small part of MI, the primary foundation of MI. So what does it help accomplish? It resolves that ambivalence that you all have just experienced in your concept application. It helps to drill down to a patient's real issues as to why they're having difficulty with the change or anticipating difficulty with a change, understanding how patient feels about that change, Y'all, there are so many things that we are missing because we simply aren't asking the patients, how do you feel about going home? How do you feel about transitioning to home care? How do you feel about home care being discharged and you managing this independently? We've got to go there because that will evoke some of those issues that may in fact be problems for the patient after we're gone and create the noncompliance that causes readmission. Develop and maintain rapport. Remember, that patient is truly in charge. They are the ones that decide in the middle of the night whether they're going to go to the ER or call their healthcare provider. So we've got to recognize that. Sometimes there are things we cannot change. But if we maintain that rapport and understanding through the type of conversation we will have, then we will at least be the provider they choose the next time they want a provider. Establish that partnership, and most importantly, it evokes that change talk out and from that patient. So open-ended questions explore that ambivalence, the benefits of changing. Open-ended questions in the clinical setting where we have very little time. We may only have 10 to 15 minutes if we're in the hospital, 10 minutes sometimes at most, maybe not even 5. But we do know that in as little as 10 to 15 minutes, the stage can be set for behavior change to occur in an individual when these types of questions in a conversation are used. Please let that be another second very important takeaway. How will change affect my daily life? How to move forward with this change? What is realistic and doable to change for me as the patient? What is the level of importance I associate with the change? And what's the confidence level I have that I can do it? These things are wonderful things to explore with a patient that typically in the past we haven't explored. So what does this sound like? Tell me about the most important concern you have about discharge. How do you feel about your progress? What benefits do you see if you could lose weight? And look at how we phrase this. If you could, if you choose to. This is all part of that patient empowerment because remember, they make the decision in the end. It's not about what we say in terms of knowledge. It's not about what we teach them. It's about what we evoke from them, that we draw out of them about it, okay? Describe what this change would mean to you. And remember, we try to move this in a positive direction because that's what we want. Better outcomes, improved health, and so forth. How will this impact your daily routine? How will this change your family? You'll notice these are open-ended in that the patient has to expound on their response. It's not a yes, no. And that's why it's so hard for us to embrace an open-ended type of conversation from our perspective because we've been trained unmercifully to simply ask yes, no questions, okay? So it's not all our fault. We got to feel better about that. Okay, very quickly, are these open or closed questions? Is your family supportive? Tell me what's most important to you about this. Do you have any concerns about this? Tell me what you believe about this. How much did you drink over the holidays? When is your next appointment? Explain what you mean by that. Is this an open-ended question? Okay. Number 1, that would be closed. Number 2, open. Number 3, closed. Number 4, open. Number 5, closed. Number 6, closed. Number 7, open. And number 8 is closed. Let's practice writing an open-ended question. Now, I really fully wouldn't expect you to be 100% on this because we've gone through this very quickly. If I could just lose enough weight so I don't have to start those insulin shots, what is an open-ended question that you could, or a statement that you could respond to a patient who makes this statement? I'll give you about 15 seconds.
Hey, Melinda, this is Misty. I'm going to jump in here real quick. If folks want to use the chat feature, you can go ahead and send those in through chat, too. We'd love to see what what your thoughts are there.
Okay, now let's take a look at some of the, and the neat thing about it is there's not this is the only correct way to respond to that patient. You can respond in so many ways. Here's some examples. Describe how your weight loss will do this for you. Now remember, the way that we're phrasing our conversation has to do with what that patient and the patient change behavior, what the patient can do to actually create an environment for his own or her own change that is going to be made. Tell me the concerns you have about losing the weight. When they answer this question, you're going to know what kind of problems they're going to have with complying. Even though they may want to, they've already said, they've indicated, look, I know that insulin shots will help me. I mean, I can come off of those if I can lose some of this weight. Now, we know that there's some teaching that has gone on prior, or maybe there have been, they've been a patient with diabetes for some time, and they know that this is something that does affect that. How do you feel about your progress thus far? What benefits do you envision if you could lose the weight? Therein lies some of the motivation that we try to tap into. If we can find out what their motivation is, then we're going to hone in on that, because therein lies what can help us guide that patient properly and eventually help them to have success. Describe what this change would mean to you. How will losing weight affect your family and your daily routine? Those are some examples of great responses that you could give. Affirmation. Now we're going to move through this a little more quickly because I do want to touch upon patient resistance before our time runs out. Affirmation means we're validating that person's strengths and their struggles, their skills. It helps them build confidence that they can actually make this change. An example, it's not uncommon to feel unsure if you can lose the weight. You have strong family support to tackle this. You know what will work for you. Now, these kinds of examples are in response to comments that that patient may make. Another part of voice is reflection. I hear you, it builds rapport, it allows that patient to hear what they're saying, because remember, the more they talk about change, the more likely they are to what? Make the change. Examples. And a reflection is very close to what you've heard that patient say, because we want them to hear what themselves are saying. You want to stop overeating, but you just can't resist at times. Exercise is not on your list of favorite things to do. You know that weight loss will have a positive impact, and let them ruminate on that. Let them think about that. Summary, today we've discussed your anxiety about giving yourself insulin shots. You recall that your mother had difficulty with her injections when you were growing up, and this gives you hesitation. Our next time together, we'll review the steps in detail and look at the options for administration. Then we'll go from there. There's a lot of us who aren't giving summaries. The important thing about a summary at the end of your visit or at the end of your encounter with your patient at the bedside or wherever that patient is that it helps you and that patient connect on next steps. What is expected? It helps with accountability, and it also helps that patient, gives them another opportunity to correct what you've heard in the conversation, and also for them to have that opportunity to say, you know, I'm thinking about that. I'm not really sure I can do that. Okay? Very important. Now we're getting to resistance, created by the healthcare provider, and we call that angels unaware. The writing reflex. It's a natural tendency to resist persuasion, and we do it all the time in healthcare. The writing reflex. When decisions are difficult, we generally feel at least two ways about this. It's an internal argument that is already going on. I would exercise in the evening, but I get home from work late at night and I'm just too tired. Okay, there's an internal argument there that we're having within ourselves. So when we try to correct or write someone about this, they're going to naturally take up the other side of the argument, thus sustaining where they are. We've got to avoid creating resistance. Remember the scenario with my dad. but you want him to breathe, don't you? Instead of, when my mother said, I don't want that oxygen tank in my house, instead of missing that wonderful opportunity by saying, but you want him to breathe, don't you? That nurse should have immediately said, what is your concern about having the oxygen tank in your house? I want to help you understand. I want to hear what your concern is about that so we can help you with that. Do you know my father did not go home with oxygen because my mother resisted it so heartily? That one instance could have changed the entire scenario and should have. Resist the urge to convince somebody they've got a problem or to argue for the benefits of change. She was arguing, in a sense, with my mother about how my mother felt. Do you understand what I'm saying? I think it's important to, if there's a third takeaway, please understand that we're creating resistance without being aware. And we don't have to be ugly to do that. We can cheerlead and totally dismiss the patient's concern because we're not listening and because our agenda says move on. We got to keep moving. There's too much for us to do today. We're missing opportunities. Resist the urge to tell somebody how to change. I can't tell you, and I almost have to laugh because it's comical. When we get clinicians in a room in a coach clinic and we conduct those nationwide, we have a full day event where we go into a company and we're conducting a coach clinic and we have hours of practice and it's a lot of fun. People will say, I will hear them as we're going through and we're supervising some of the sessions and asking for input. It's really kind of comical because we'll hear over and over people telling someone how to do this. Well, have you thought of this? Well, have you thought of this? Telling their patient how to change, because we do role play where we have both clinicians. One is playing the role of the coach and one is playing the part of the patient, but we use real health issues for that patient, the real issue that, let's say that I have about cholesterol. I'll have some, the health coach is coaching me about my real problem. But that's not getting that patient to expound on what might work for them. Does that make sense? If I keep giving them all I have no idea what that patient is willing to do. They need to come up with those things they're willing to do. You've got to think about why that's important, because you're wasting a lot of time. Clinicians waste a lot of time going into things that don't matter, because that patient may not even begin to want to do those kinds of things, or may not feel like it's important. They may not feel like they can. Remember what we said, there's all kinds of reasons why people don't change behavior. And we've got to avoid trying to warn them of the consequences so sternly that they cut us off. Now, when it comes to physicians and other prescribers that have within their Practice Act the responsibility for going over the risks and the downfall, that's a different story. But I'm talking about those who are in teaching roles. We've got to be careful about using and creating these types of resistive interventions. So what does it sound like? Convincing? Reservation cigarettes say that 100% are natural, but they're really not. And that's if you're working with someone who's trying to quit smoking, they're living on or near a reservation, and those cigarettes will say 100% natural, but they're really not. You're trying to convince that person. And the person personally at that moment is using those cigarettes. So remember that internal argument. They're going to take up the other side of the argument and resist you. Arguing. You want to breathe, don't you? Telling how. Well, if you don't feel well, this is certainly reason enough to come into the clinic or to keep that doctor's appointment. We're telling them how to do it. Warning them, look, you've got high cholesterol. You've got to get that down. You've got to get that blood pressure down. You certainly don't want to have a stroke. And sometimes we can be totally dismissive, which may not create resistance, but we miss wonderful opportunities to connect with our patient. In terms of, oh, don't worry about that. We've got a wonderful dietitian who'll be able to help you. We're dismissing their concern about that. Now, maybe the dietitian is the best one to reach out to that patient, and we can make that referral. However, we've got to right then be sure that we're opening a door. Look how much more meaningful a referral would be to someone when that RD gets more information from you rather than a diagnosis and a general progress note. What is important to that patient? What is going to be an issue for them, if in fact you've been able to determine that up to that point? And how to empower, asking permission, giving information, and if we do give suggestions, ask permission to offer several. And what's so important about that is this: would you consider, would you be interested in hearing how others have done well post-heart attack? Do you have any objection to my going over some of this information? We've got to find out, too, what they know. That's the elicit, provide, elicit. It shows respect in terms of we don't just give them information without finding out what they already know. Remember, this is the information age. So we've got to find that out. If someone has diabetes and we know that they've had it for, let's say, several months, we may consider them, if they're newly diagnosed, we still don't need to assume what they know or they don't know. May I give you some reading material about XYZ? Remember, this type of thing empowers that patient in that partnership. It empowers them in their eyes, and it also says to them you respect them as being a very important person in the relationship you have with that patient. Let's do just a little practice, a taste of MI. Over the next 60 seconds, I want you to respond either with an open-ended response, and I would encourage you to think about open-ended because you can't possibly learn that in one time. Use a reflection if you feel like that would be good. Use an affirmation if you would like to. There's all different ways you can respond to patients. And depending on how the conversation has gone up to that point is when you decide what to pull from your knowledge base as to how to respond. But you choose how to respond, and let's do this. Take your pen or in your chat box. I bet you're going to tell me I got to go on a low-fat, low-salt diet. How would you respond to that patient?
And this is Misty. I'm just going to remind everybody to, if you'd like to, you can use the chat feature to put your comments in there to share with all the panelists. If your chat window isn't open, you can click on the little chat bubble up in the upper right corner of your screen. It'll open that up. You can also use the Q&A feature, and that'll be visible to all participants on the webinar.
And I want to give you a good 60 seconds to think this through. If you can write a couple of responses, that will even be better. thank you all so much for participating in this. We have a group live practice for our members, those who take our program, and we'll spend an hour in this group live practice. And I appreciate those of you who have entered into the chat box, because one of our ways that we do group practice is to look and critique all the different responses coming in. And our members love this because they're able to learn from each other and learn how to improve on the comments that are coming in, because as you know, and you've experienced now, that there's lots of wonderful ways that you can respond to this patient. But practice is the key. Practice is important. I want you to think about this when your patients are talking to you. I want you to begin to think, as we do in this case, I bet you're going to tell me I've got to go on a low-fat, low-salt diet. My first response to this would be, the low-fat, low-salt diet is not exciting for you, because they're giving you a clue there. I bet you're going to tell me I have to do this. They are not looking forward to it. So anything else beyond that right there may not get down and drill down very quickly to their issue. But now this is after 10 years of working in motivational interviewing and working with patients. I certainly wouldn't expect you to have that degree of skill at this moment. But, and what all you've done and what I've seen in the chat room, the chat box is very, very appropriate. But begin as you think of the fourth takeaway for today is, as your patients are talking to you, really listen. And again, part of our program is active listening. How do I listen to this patient and pull out where I can get to their issue? What is their dilemma that they're expressing to me without maybe saying it directly? And you will get so much further, much more quickly than we've ever thought possible in the past. Take a look at this as we begin to wind down. Look at how we might traditionally respond to that comment. You'll do just fine, we're here to help you. Another one, your blood pressure and cholesterol have got to come down. You certainly don't want to have a stroke. Better to be on this diet than deal with having a stroke, okay? And you can do that and be very nice, but what are we doing? We're totally dismissing. We're trying to tell them, we're trying to argue with them that we want to right them. That righting reflex comes on strong in their response to us, but we want to correct them. We don't want them to have a stroke. We don't want them to have a blood pressure and cholesterol problem. But we're going about it. I would suggest to you, I would submit to you that we're going about it in ways that can be improved upon. So let's look at some ways that we can, and some of you have mentioned this already, and I'm so proud of you. I bet you're going to tell me I have to go on a low-fat, low-salt diet. Yes. What do you know about this diet? Yes. What benefits will this have for you? A reflection. Yes. But you sound let down about this. Let them think about it, and then a follow-up with an open-ended question. What are your thoughts about this? Okay? Everybody with me on that? Okay. Now, if you have any interest in talking to us further about how do I get these skills, I have an interest in these skills, then you can certainly look on your handout and know how that you can call us, and we'll be glad to answer any question that you might have, or email us. That's fine too. We're happy to help you any way that we can, or to guide you in any way that we can. I'm all finished. I would like to take on some questions now, if I may, and I am going to turn it back over to Cindy.
Thanks, Melinda, and we want to thank you for all the content. I want to remind everybody to use the Q&A feature on the right-hand side of your screen. Send in any questions that you have. You may be at the point of just trying to grasp it all, because this is a lot of content. And you did a really good job of getting it all to us. I don't know about the rest of you, but I've got my scribble page here of all the different ideas I had. While we're waiting for the Q&As to come in, I'm going to go ahead and move into our, you can see Melinda's references here. And then we also want to go ahead and talk about a few of the resources, but please get your questions in. These links are to the HHQI resources that I think most of you are already aware of, and you will see as you go through these that Melinda's been a contributor to HHQI for quite some time, and we do appreciate everything. That you're just a wealth of information. Next, we're going to move into how to obtain your nursing CEs for those of you who are interested, and don't forget, keep the questions coming. We want to get those answered if you have any. As far as continuing education, I'm going to tell you right now, if you have not been on this type of webinar in the past, what I'm getting ready to tell you is going to seem exceptionally complex, but it's really not. Trust me, I've done it. So follow these steps to get your CEs. If you click on this link at HHQI University, and also at the end of this webinar, you will be directed to HHQI University, and you'll go ahead and log in. It's in the green box here in the middle. Once you're there, click on the title of this presentation, Partnering with Patients, and it will take you, it's inside of the Disease Management Course Catalog. Click on the Apple Enroll, and then click on My Account. The green box icon in the View column, and finally the green icon in the Action column on Lesson 1. In order to receive the CEs, all you need to do after this webinar is complete the reflective question and evaluation, and once you have done this, click on My Account, and you can download and print your certificate. Something that has come to our attention in the past few weeks, if you are trying to print your certificate from an iPhone or iPad on any of the HHQI University courses, it is not being successful at this time. We have recently learned of the most recent iOS update. It caused a glitch in the system. You still have passed the course, you still have the certificate, you just cannot print from that. In other words, if you want to print your certificate, you can do that from a regular computer or laptop. If you don't have access to that, contact us and we will send you the PDF and you can print from there. And this is not long-term. This is just short-term. I will just go ahead and address the one question that's asking about the slides. Yes, they are available under the HHQI Cardiovascular Learning Action Network webinar tab on the HHQI site, and that's the same place where you registered for this. Now, Melinda, let's go ahead and answer a few questions if you don't mind. There's a question coming in that's asking, would you suggest obtaining a health coach certification or MI certification first?
That's a very good question. What we have learned is that from some disease management companies is that when they taught motivational interviewing only, they had a very difficult time with clinicians not making the transition, and they did not do well with implementing these new conversational skills. So we definitely suggest that you select a program, whether it's ours or another, that would have evidence-based health coaching with motivational interviewing as its foundation. That is critical for you to be taken through some more of the transitional steps to change your mindset, because what you will find that will happen is that the concepts may seem fairly easy to grasp and to learn, but when you apply them in actual conversation, you will begin to revert back because of all the years of training and experience with the traditional way of managing and guiding patients and teaching them. So it's just imperative that you go through that training for a transitional mindset. So that's why we encourage health coaching with motivational interviewing. And whether it's certification, we have a lot of people, well, I shouldn't say a lot, primarily people take our program for certification, but it's not required that you test for that. We have some people who will simply take the program for educational purposes and not test, but we give free testing attempt, one free attempt in that 12 months that you study the program, so you've got plenty of time to test if you choose to, and it doesn't cost anything extra to test.
I'll just give my voice of experience, whatever it's worth, for those of you out there. I've been trying to implement Melinda's practices and health coaching and motivational interviewing into my daily routine for quite some time now, and I relate it back to, as we all learned in our programs, where we had to learn therapeutic communication skills, whether it's your first week of nursing, therapy, social working skills. That's when we were learning, and you learned it was a different way, a different mindset, and that's what it's habit to ask yes or no questions, and it's not, and to convince somebody. And I've been working very hard at this for a while, so thank you for addressing that, because it's not something that, it sounds so simple and it's so logical, but it doesn't work that way. It takes practice.
It's not as easy because we're not accustomed to it. And I do believe that our programs, and we have universities who contact us frequently for suggestions on curriculum and even involved in taking our program at that level, because they want to begin. They understand now, just beginning, some of the universities and colleges are just beginning how important it is going forward in this new age of healthcare that our country is going through and beyond, that we get that patient involved. And we've got to know our patient better and get them actively involved in their own care. And this is one way of doing that. So when they learn at that level, at the collegiate level, or even at the associate degree level, at the LPN, any healthcare provider, it's important that whenever they get their training to include it then, so that their mindset doesn't have to be changed going forward. They can learn it that way from the get-go.
I think that's wonderful. You're changing it, and that's where the change starts. For those of us that are a little beyond that, it's harder to integrate it. So
it is harder, but it's so much fun once you begin. When you get out there and just begin to touch upon some of these things, it's just so much fun. And the patients just, oh my goodness, you know, it has been such a boon in satisfaction and in some use of urgent and emergent care rates. I mean, we're really very pleased with what we're beginning to see happen. And again, it's still pretty new, but we're very encouraged.
I'm glad to hear that. And that's
I think we might have lost Cindy's audio.
Now I can hear you.
Yep, it looks like I actually just got disconnected a second ago, but was able to jump back in real fast, so I bet the same thing happened to Cindy.
Okay.
Yeah. Now, I'm not sure how quickly she'll be able to get back in, but we are just about 2 minutes till. I don't know if you had any, just final thoughts you'd like to share, Melinda?
I didn't have any closing thoughts other than it's been my pleasure to have been invited again, and thank you so very much. And again, we're willing to help in any way that we can. Don't hesitate to contact us.
All right. Thank you so much, Melinda. And I'm going to give Cindy just a couple more seconds here, see if she can get back in. I know she wants to tell everybody thank you as well. And I appreciate everybody's patience. Again, everybody who came back since from the original broadcast and was patient enough to deal with our technical issues that time around.
Yes, absolutely.
So glad we were able to get this back on the calendar so quickly. And I believe the majority of folks that were registered for the first time were able to come back in. So that's great.
That's great. Thank you.
All right, I'm going to go ahead and end the event for the day. Thank you again for joining us. On the screen there is our contact information. If you have any questions, you can contact us at hhqi@qualityinsights.org. If you have any additional questions for Melinda that we weren't able to get to today, please feel free to email us those, and we will be sure to get those over to Melinda. So thanks again. Take care.